Hello. Welcome everyone. How you doing, Robert? How you doing, Courtney?
Good, good.
Good, good. Thumbs up. Everybody had a great day, great week so far. It's moving pretty good. Good, good, good. How was pinning last graduation? Pinning, right, Robert?
Yeah, bit busy.
Busy, busy, busy.
Very,
How many
very
students
busy.
did you graduate?
We graduated 61.
Wow, it's awesome.
Yep.
Awesome, awesome, awesome. Awesome, awesome, awesome. Courtney, everything going well for you on your end?
Yes, just very, very busy.
Busy, busy,
Everything.
busy.
Yeah.
Wow, you're gonna get a
How about
break.
for you?
It's going pretty steady here too. We
Yeah.
ended our semester but started summer school first semester, first session like the next week. Graduation was on Saturday and first day of summer session started Monday. So we've been pretty steady as well. Yeah. Hi Kelly, how are you? We missed you last week.
Good. I was here last week. It was the week
Were you here
before.
last week? Okay, okay, okay. Yep, I do have you down. I thought you was someone else.
Yeah, it was the week
Kristen. It was
before.
Kristen. Yeah. For some reason I saw your name, but when I saw your face, I thought I saw you remind me of a Christian. So, you know how you can look at someone. Yeah. But I do remember you were with us last week. We had a where's your buddy? Where's Andy? Is he busy, busy, busy too? Everybody's busy. Well, I hope everybody's doing well. We'll go ahead and get started because we have a full evening as always. We will start our recording is already started for us. You'll see our schedule, our agenda for tonight. So a little maybe shy one or two sets of questions tonight, but we still have 40 questions we'll get through on tonight. We'll do our 10 dictionary terms. And then we'll take a break after the first set of 10 questions and then we'll finish up our last set. I may take a pulse on just how you're feeling once we finish chapter 14. And if you feel okay, we may go ahead and do 15. If not, we'll take our time. Remember, this is the where we go into 40%. This domain here, part of the plan, the test plan, we are actually 40% in. And this is the one where I said we were going to divide it up in half. So we'll take our time, just really making sure we understand. So really pay attention, highlight those questions, those areas, those concepts that don't feel you're just having to guess or you're just not quite sure because 40% of the CHSE exam is coming from this area, the area that we're doing this afternoon, and the one we'll conclude on next week. Can you believe it's already week 4? We're moving pretty fast, and you are actually doing really, really well and hanging in there with me. So, any questions before we get started? We're all good. If everybody's all good, we're a thumbs up. And we'll go ahead to our dictionary questions. Awesome, awesome. Our dictionary terms. So our first one on this afternoon is high fidelity. High fidelity. We've been talking about a few of them, but just wanted to make sure we actually went over the term itself. High fidelity. And we talked about that's where the chest rise. It really is realistic, really mirrors human or real a situation, real vital sign, heartbeat and healthcare simulation experiences that are extremely realistic and provide high level of interactivity and realism for the learner. It can apply to any mode or method of simulation, human, mannequin, task trainer, or virtual reality. High stakes assessments. Our high stakes assessments are the ones we really want to make sure that when we're using those evaluation tools that your evaluators have been trained because they really have to know how to use those assessments, making sure that the assessments are valid and reliable. So when we're looking at high stakes, we're looking at those type of assessments that has major academic, educational, employment consequences, such as grading decisions, pass fail implications, decisions regarding competency, merit, pay, promotion. But in our area, we're looking for those are those assessments that are pass fail, your summative assessments. Our next term is hybrid simulations. We've touched on that as well. Just wanted to make sure we saw the definition, the combination of simulation paradigms in healthcare simulation, hybrid. Let's see. Simulations, or when we'll have a simulated patient or a task trainer alongside it. A part task trainer urinary catheter model is realistically affixed to a standardized patient or simulated patient, allowing for the teaching and assessment of technical and communication skills in an integrated fashion. We've talked about that. Our next term we're going to is in situ. Those are simulations that typically occur inside of your healthcare, your hospital systems. But in situ, by definition, is defined as an activity that takes place in a patient care unit and involves team members in their own work environment, actually taking place in the patient care. When we're doing the in situ sims, we have to really make sure that everything inside of that hospital setting or that patient care setting that is simulation related has to be marked for human use only. And making sure that those things that are used for the patients in that healthcare setting is definitely not in the same place where your simulation equipment and supplies are. Interprofessional, those are more contemporary term describing a team effort in healthcare from two or more professions whose members learn about from and with each other to improve health outcomes. And we've talked about that as well. Some of the factors that impact putting together or creating interprofessional simulations is time factors, scheduling, and those logistics that kind of interrupt because you have more than one profession coming together. A lot of times they just can't all get on the same time frame. And also making sure when we're creating these type of simulations that there is a representative from each profession around the table, making sure to plan those objectives. And also they are participants in the evaluation process, in the debriefing. Just-in-time simulations, method of simulation-based training that is conducted directly before the learners need to perform the intervention. Appropriate clinical information is given at the right time and place. And that can be a procedure that's done right before a procedure has to happen. They can bring the team together and actually do that procedure so that they would know how to do it when they really have to do it. And sometimes it's done right before. Learning objectives, we know drive our simulation scenarios. And so specific measurable steps to help you achieve your mission and set benchmarks for achievements. You have to make sure they're smart, simple, measurable, achievable, realistic, and have a time stamp to them. Low fidelity is the opposite of high. We don't have no chest rise. That's usually your task trainers. Not needed to be controlled or programmed externally for the learner to participate. Examples include case studies, role playing, or task trainers used to support students or professionals in a learning, a clinical situation, or practice. Mixed reality, you have a combination here of hybrid combination of virtual environments and reality to create a new environment. Modality, we've talked about that. We've heard that term, is the platform for the experience and includes simulated clinical immersion, in situ simulations, computer assisted simulations, virtual reality, procedural simulations, and or hybrid simulations. These modalities may incorporate but are not limited to the following: standardized patients, mannequins, haptic devices, avatars, partial task trainers, and so forth. They build a simulation-based experience to align the modality with the objectives. Remember, the objectives drive the simulation creation. So those objectives will let us know what type of modality we need. If we're doing psychomotor, evaluating the psychomotor domain, and we may not always need a high fidelity simulation. Can probably more than likely can do that with a task trainer. So making sure that you know the objectives and you choose your modality after your objectives have been created. It drives that simulation experience. And our last one for this afternoon is OSCEs. Station or series of stations designed to assess performance, competency, and individual clinical or other professional skills. The learners are evaluated via direct observations, checklists, learner presentation, or written follow-up exercises. Exams may be formative and offer feedback, or summative and be used for making high-stakes educational decisions. See that a lot in your high-stake environments, used as a summative, but it can be used as formative if they're providing feedback along the way. But when we're in that high-stake environment, just as we saw a term earlier, that's pass-fail. Objective, structured examinations of student actions in a simulated clinical situation. Okay. All right. So we'll look at what chapters. We're going to do chapter 4, educational theories, learning, and special concepts. Chapter 15, implementing simulation in the curriculum. Chapter 16, planning simulation activities. And then we'll end this afternoon with chapter 17 on debriefing. In your folder, there is a educational learning theories, because we will be doing theories on this afternoon. And that's the chapter we're getting ready to start. Do the questions in. And again, like we talked about at the beginning, whenever you're looking at your theories, they're not asking you to do recall, but what does that theory look like when you see it in simulation? How is that theory enforced? And so I do have a document inside of your folder that you're able to take a look at and actually see where you have the theory, what it's about, and then you'll see some examples as aligned into simulation. I do encourage you. I've had feedback, positive feedback regarding this document when taking the CHSE. So please make sure you look at it. If you're struggling with theory, theory sometimes is one of the tough ones because we don't talk about theory all the time. But as an expert in simulation, we are expected to understand what those theories are and what they look like in simulation as we align our simulations and actually using the theories as a foundation. So I did want to show that to you this afternoon as well. Okay, so we'll go ahead and we'll start our first chapter 14. I hope both of you have had a great day so far. Hope all is going well. All going well, Andy? All going well?
It's going well. Just a long day.
Just a long day. Yeah. All going well, Miss Free? Cordelanda?
So far, so good.
Awesome.
How about
All right.
yourself?
It's going well. All is going well. We're moving fast. I told them we just started summer session 1. We're already in week 2, and it's moving really fast. Yes.
It's moving.
Yes. So thank you both, and thank everyone for joining us on this afternoon. So we'll go ahead and get started in chapter 14. If everybody's thumbs up, we'll go ahead and get started. We'll make sure all right, I see it. We will use the chat box and put our answers, and then I'll wait a while, pause, and then give the correct answer, and then we'll go over the rationale. Okay? So page 237, chapter 14, the first question, a healthcare simulation educator is developing a scenario for a student to learn newborn care and would like to use the constructivist theory as the foundation. The best method would be to A, have the student repeat a newborn assessment several times to get the procedure correct. B, decide after pre-briefing the student's previous experience with newborns. C, develop a scenario that changes the newborn's status if an assessment is performed wrong. D, change the newborn status to mimic a healthy newborn if the assessment is done correctly. Correct. Our answer is B. Our answer is B. So we're looking at the constructivist theory. So someone would like to tell me why A, C, and D is incorrect? Because B is our correct answer. Decide after pre-briefing the student's previous experience with newborns.
And each of the, excuse me, other answers could be explained by different theories and not the constructivist one. So that's kind of how I just eliminated them quickly.
Okay. And when you think about the constructivist theory, you always, I like to describe it as you're constructing or you're building, right? So you start off with something and then you build upon that. So what is the previous knowledge of your learners and you build upon that knowledge? It's almost like a scaffold. You kind of keep moving forward. But when you look at A, have the students repeat a newborn assessment, that word repeat, meaning that we're providing feedback and it's actually changing the behavior. So that's more of the behaviorist. When you look at C, develop a scenario that changes the newborn status. If an assessment is performed wrong, again, we're looking at changing that behavior. And because we've changed it based on what the student did perform wrong, and the same thing with D, changing it based on the student doing it correctly. But when you look at B, it says decide after pre-briefing the student's previous experience. So based on what they previously known, their previous experience with newborns, that's when they were able to develop the next scenario. Okay. All right. Thank you, Kelly. The constructive theory should build on previous knowledge, and the teaching learning modality should be established to fit the student's learning needs. Understanding what the student's previous experience is after the simulation educator pre-briefs the student about the assessment is a good idea. Having the student repeat a newborn assessment several times to get the procedure correct reflects behaviorism through demonstration of repetition. Developing a scenario that changes the newborn's status if an assessment is performed wrong, and changing the newborn status to mimic a healthy baby if the assessment is done correctly is stimulus response method or behaviorism. So that rapid practice, that they would deliberate practice and providing feedback as they continue to practice and then changing, that is more changing the behavior. Number 2, the students need additional understanding when they state a constructive approach to this scenario includes A, using the material we learned yesterday and applying it today. B, starting with what we know about this situation and then assessing the patient. C, approaching the patient as if we have no information. Or D, relating what is similar in this case to the other cases we've worked through. And our correct answer is C. Because again, we're looking at constructivist theory. They're saying the student need additional understanding. So they don't understand when they say that we're approaching the patient as if we have no information. Because remember, with the constructive, your student have some information, they have some content, and then you're going to build that scenario or the next scenario based on what they've learned or what they already know. And A, B, and C, the keywords in A is we learned that yesterday, what we know about this situation. And then D, we have worked through it. So that also says that the students had some prior experience with the content. So C is your answer for that one. Approaching the patients if we have no information is not congruent with the constructivist theory, which builds on past experiences. The constructivist theory builds on what the student already knows or has experienced. Therefore, using the material you learned yesterday and applying it today, starting with what we know about this situation and then assessing the patient and relating what is similar in this case to other cases we have worked through are all related to past experiences. Number 3, doing a team-based simulation scenario, one student takes the lead and approaches the patient first and takes the blood pressure when the mannequin tells the group that they feel lightheaded. The student who assesses the blood pressure is displaying which learning style? Concrete experience, abstract conceptualization, C, reflective observation, or D, active experimentation. Yes, our answer is D. Who would like to talk about that one? Concrete experience, abstract conceptualization. That's Kolb's learning theory. So make sure we take a look at that. Kolb's learning theory. So why is D correct when we think about Kolb's? Or what in the question really supports Kolb's learning theory, active experimentation? What are your key?
Hands-on part
Mhm.
of actually doing the skill.
Exactly. Their response. They saw the patient's symptoms and they responded by doing the blood pressure. You are correct. Thank you, Shelley. Active experimentation is using hands-on experience to learn the skill. Concrete experience, taking the initiative to obtain the blood pressure is not an example, but because it builds from the reality. Abstract, thinking about what to do, not thinking about what was to do. Taking the initiative to obtain the blood pressures is not thinking about what to do. Reflective observation, taking the initiative to obtain the blood pressure is not a reflective looking back activity. Number 4, the simulation healthcare educator has developed a simulation scenario based on the scaffolding learning theory and presents it to a group of students. The students are provided with an explanation of the case that becomes increasingly difficult. The group was unable to formulate a comprehensive plan for the patient. One learning element that is most likely missing may have been A, instructor present, B, realism, C, constructive feedback, or D, knowledge. Yes, here again, C. It wasn't that they needed that feedback, right? Feedback, again, forming learning along the way. It provides and helps them know how to move to the next level, what they need to do next. And this is a scaffolding approach where we start at one level where the students are, and based on what they've learned, based on how they respond, we move up to that higher level and we continue to escalate or continue to develop scenarios that are harder as you move the students through the concepts and through the program. So constructive feedback is your correct answer. In the key in that question, based on the scaffolding learning theory, the keys were with an explanation of the case that becomes what? Increasingly difficult. Okay. Instructor presence. Let's see. Constructive feedback may be a missing element to the student's inability to construct a plan. The 4 components of a Vygotsky scaffolding learning theory are constructive feedback, explanation and reflection, and revision of knowledge. Instructor presence is not warranted to construct a plan. Realism is not part of formulating a plan. Knowledge is present, but there is no indication that a revision of that knowledge was necessary. Vygotsky. Guided by social learning theory, the healthcare simulation educator demonstrates to a student who has low self-efficacy how to insert a chest tube correctly. The principle that the healthcare simulation educator is using is A, mastering experience and learning, B, vicarious experience learning, C, verbal persuasion, D, physiologic state. Yep. Learning through someone else, experiencing the same thing as that other person through that person. B is the correct answer. Healthcare simulation educators using vicarious experience learning because the student is what? Observing the healthcare simulation educator's demonstration of that tool. And through that demonstration, they're able to learn. Mastering experience learning is incorrect because the student is not demonstrating their own history of success and is inactive during the simulation. Verbal persuasion is incorrect. There is no evidence that the healthcare simulation educator is providing verbal encouragement. Physiologic state is not correct because there's no evidence that either the healthcare simulation educator or the student express success in achieving the chest tube insertion. Number 6, one of the healthcare students was previously an emergency room medical technician, an EMT, and during a simulation briefing, they stated that they would like to advance their splinting skills. The student is demonstrating which type of educational concept? A, pedagogy, B, realism, C, behaviorism, D, andragogy. That's the adult learners, right? They knowledge, bring knowledge to, and desire. How is it going to make me better? How am I going to grow? How am I going to be stronger? Is correct. D, andragogy is correct because the student is expanding or advancing self by building on their past experiences. Pedagogy is a method of learning used to teach passively, and we mostly see that with our younger students without previous knowledge. Realism refers to the fidelity of the simulation and does not apply in this situation. Behaviorism is not correct because there is no evidence that the student is demonstrating learning through a behavioral change. Number 7, the new healthcare simulation educator needs additional information when they provide a list of Kneebone's simulation learning principles as A, occurring in a safe environment, B, tutors being available to learners, C, teacher-centered, or D, mimicking real life. Yes, I love it. C, yes, we roll it right through. C is our correct answer. More teacher is student-centered instead. It's not teacher-centered. And it really mimics simulation. It's not about us. It's about the learners, right? The educational approach that we have to our students in simulation. His simulation principles include a student-centered, not a teacher-centered. It's not about us teaching and showing how much we know about that concept, but we're really creating this atmosphere so that we can find out what the learners know or what they don't know so that we can help them close those gaps, right? Additional principles include simulation occurring in a safe environment. Yes, want to keep it psychological safe. Having tutors available for the students and ensuring the simulation mimics a real life. So C was our answer. 8, Kirkpatrick's. Simulation learning principles are orderly, and once learning is achieved, the healthcare simulation educators should expect the students to A, react to the debriefing questions, B, apply the learning to patient care with positive outcomes, C, learn through a pre-module requirement, or D, demonstrate a change in behavior. Kirkpatrick. Yes. Yes, Kirkpatrick. Our first level is reaction. How do you feel? What did you learn? What behavior will change? And what are the outcomes? Right? And we do it every time whenever our students, when we get them in debriefing. So it's correct. So the question says, once learning is achieved, what will the healthcare simulation educator expect the students to do next? So your learning has been achieved. Now you're going to clinical. So I expect some changes. I expect that behavior to change when you get in clinicals, right? And that's B, apply the learning to patient care with positive outcomes. Okay. React to the debriefing questions. That's level 2, right? What did you learn? Level 1 will be, how are you feeling? I want you to tell me how you're feeling. Everybody okay? Or just how are you feeling? And you go around and have everybody tell how they're feeling, what went well, what you don't think's going well. And then it says learn through a pre-module requirement. That's that level 2. What did you learn? And then D, demonstrate a change in behavior. And that's what we see them going out there in their clinical. We take them to clinical next week or the next day. We should see them doing better, especially if they struggle in medication administration. You're hoping that when you get them in clinical, they're going to do a little better. That level 4 is the highest level, and that's usually what we see. And you don't see a whole lot of that in literature, but we want to make sure that if we're able to observe the care that our students do provide, did it produce any outcomes to the patient? We may be on
Dr.
our
Scott,
units. Mm-hmm.
sorry to interrupt. Andy just texted me and he said he was in the waiting room if you could let him in.
Okay.
Just because he
Thank
got
you.
his app crashed and so he had to reset.
Oh, okay. Thank you. Let me see. Thank you.
No problem.
I'm gonna wait for him to join. Sorry about that, Andy. I didn't see you. Thank you so much. Thank you, Kelly. Okay. Let's see. Up the number 8, apply the learning to patient care with positive outcomes is the highest level in Kirkpatrick's pyramid. Reacting to the debriefing questions is an example of level 2. Learning through a pre-module requirement is level 2. Demonstrating a change in behavior is level 3. Number 9, the last step of Durer and Murray simulation teaching learning process is A, debriefing, transference, B, C, developing learning outcomes, or D, creating a situation. The last step. Correct. Oh, hold on. Let me see. Let me get you. Yep, B is correct. B is correct. Transference. How did they transfer? The last step. Step 1 would be we come up with our outcomes, right? We move from there to creating a scenario. And then we're going to debrief. And then that last phase is transference. How do they transfer the knowledge learned in that simulation to clinical practice? Our hopes is they're going to transfer it in a safe way. Mm-hmm. Good. Transference is the last step in Doors and Murray's simulation teaching learning process. Taking the knowledge learned in a simulation and applying it to actual patients. So really it's not, that's why I say you don't want to learn, oh, this was Doors or Murray. I never heard of him. They're really talking about what? Simulation, how we do it, right? So not really wanting to learn the theory itself, but what does that theory look like? How does it apply to simulation principles? Okay. taking the knowledge learned into the simulation and applying it to actual patients. Developing learning outcomes is always our first step. Creating the situation is going to be your second step. And debriefing is your last step or your third step in history. Okay? And remember, our outcomes or our objectives, they're going to drive that modality, right? Okay? Number 10, a simulation educator is developing student objectives or / learning outcomes and would like to assess students at the application level. We're talking about our good old friend, Bloom's taxonomy. Which objective or learning outcomes would best fit the application level? A, defining the hybrid simulation procedure. B, discussing the clinical decision for starting CPR. C, prioritizing the intervention. Or D, evaluating the intervention's effect. I tell you, yes, 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 yes. What is the key word in C that makes that application? Prioritization, right? Prioritization. Defining, we are more or less recall, right? Our lower level. Defining the hybrid simulation is our recall level, our lower level. And then we're able to discuss, so that takes us to the what level? The understanding level, right? And then prioritization is being able to apply, being able to put in priority the based on assessment, which patients are we going to see first, or what interventions, what are we going to do first for that patient? And then evaluation, that's that higher level. Can they look at those labs and really evaluate and determine, is this patient in acidosis? Or going back and looking at their interventions as well. They go back and they give their medicine. Are they able to go back and assess to see if the assessment itself has changed? When you're creating those objectives and questions, we got to make sure that we are creating them and creating them to the level of the learner, right? Okay. How are you feeling? Are you feeling you ready to let's go ahead to the next? We got about 17 minutes left. If you want to, let's go ahead and do chapter 15. We can go ahead and do that one. Everybody good? All right. Let's go ahead. Chapter 15 is talking about how we are implementing simulation into the curriculum. Okay. Number 1, the novice simulation educator needs more understanding about integrating simulation through the curriculum when they state A, resources are needed for personnel and equipment. B, a new building may be needed to accommodate the program. C, high fidelity equipment should be purchased. D, faculty buy-in is not necessary. It doesn't affect them. D is our correct answer. Well, that's not the truth. If you don't get faculty buy-in, you're going to be in it won't work. It is important. If you're going to move that through a curriculum, you need administrative for real buy-in, and then you really need your faculty buy-in, right? So that they can actually use it in their courses, right? So faculty buy-in is important. Resources are needed for personnel. New building may be needed to accommodate the program. This is true as your programs are expanding. High fidelity equipment should be purchased. This is true because then you can use it to using those simulations that require those objectives that require higher fidelity simulators. This is true. You can have don't say you have to have a lot, but you can have them in your program. So this is true. But when we get to D, faculty buy-in is not necessary. That's where it's incorrect. It does it impacts our faculty. Faculty buy-in is always needed to make a successful simulation program. Resources are needed in both areas, personnel and equipment. A new building may be needed if space resources are scarce. High fidelity equipment will be needed for a complete simulation laboratory learning experience because it will be able to help you meet those objectives that require higher level simulators or high fidelity simulators that truly mimic a real situation. Number 2, the first step in integrating simulation through a curriculum should be A, acquire equipment, B, develop student learning outcomes, C, review the mission and values, or D, perform a needs assessment. Correct. everybody, we're going to always start out, and that's in our early planning. One of the first things is, what do we need? You always start out with needs assessment and find those gaps. And from there, you move forward to developing your outcomes. Then we're going to do what type of teaching modalities will we need to actually carry out this simulation? What type of moulage? What type of, we already said modality. And then you can look at the last one would be the acquiring of your equipment. Come down here to this other question here. Let me go back up to number 2. You're going to perform your needs assessment first, because you're looking at integrating it in your program, in your simulation program, integrating it throughout the curriculum. So we're talking about the overall simulation program in that program altogether. So really, you're going to look at the needs within the program. Where are the gaps? What do we need for this every level of the program? Okay. And then once we develop the needs, then we're going to go forward and then look at the mission and the values. What is the mission of this program? Why are we here in our city or in our community? What type of learners, and where do we want to take it? And what are the values? And then you want to move from there to developing the student learning outcomes for the overall program. Right? And then you can start purchasing your equipment, because now you know what type of equipment you will need in order to allow these learning outcomes and aligning with the mission and to close and meet the needs of the assessment, the needs assessment. Okay. Can you really see that in that order? Let's see. Performing a needs assessment is always the first step to evaluate if a simulation program is first of all needed. The next step would be to review the mission and then the student learning outcomes. The equipment can be purchased later. And you remember that we're looking through the lenses of best practice, okay? Not through what we may have seen, but what would best practice? How will we go about as an expert building a simulation program from ground zero up? Okay. 3, the novice simulation educator needs better understanding when they state that the simulation competencies should include which of the following domains? A, psychomotor, B, cognitive, C, empathetic, A, affective. Our answer is correct. The 3 domains is psychomotor, affective, and cognitive, right? Empathetic is not one of the domains. It may tell affective feeling but it's not one of your domains, right? Psychomotor, we're looking at more skill-oriented assessments, right? And when we think about cognitive, you're looking at the knowledge. What do they know? How are they interpreting? And in your psychomotor, you're putting that knowledge to action in that skill. And then your affective is looking at what? How they're feeling, what are their values, what are they thinking emotionally. And if we need to choose a type of modality, when we think about our psychomotor, what type of modality would you use if you're evaluating the psychomotor domain? Somebody unmute your mic.
You can use low fidelity if you want to do psychomotor.
Yep. And you're thinking more with your task trainers, right?
Yeah.
Your urinary insertion task trainers, your IV arm, right? When we thinking about your affective domain, tell me what modality would be your number 1 choice if you had access to it. Exactly. Yes, exactly. Why?
Because standardized patients, they're going to practice more behavior and how they're giving feedback to the patient and how they're going to discuss with them, and affective deals more with emotions and behaviors.
They'll be able to really demonstrate that in a realistic way. I love it. Thank you. Thank you. Thank you, Robert. That was good. Okay. Empathy is needed. Attribute in healthcare, but it's not a learning domain. Psychomotor, cognitive, and affective are the traditional learning domains. Empathy falls within the affective domain. Okay. Number 4, the final step of developing an integrative simulation curriculum is A, systematic program evaluation. B, deciding on teaching methods. C, developing student learning outcomes. Or D, discussing the mission. We're talking about the final step, and we just talked about that. Okay. It's part of this 40%. And we may look at these questions and say, Stop, Scott, these are easy, but I'm telling you now, we want to make sure we're looking through the lenses of best practices and not looking through our own personal lenses. So we want to make sure this is very important because, again, as a simulation expert, we're the ones that would be in that position to be able to start our programs and making sure that our programs are built upon evidence-based practices from ground zero up. So again, the final step would be looking at that systematic program evaluation, your SPEs. Okay. First, we'll look at the mission and then again, your outcomes, deciding on what type of teaching, how you're going to process the simulation in the program, what type of simulation experiences are you going to be using, and then we want to look at your SPEs. Finally, ongoing, what is simulation doing? What is the outcome of simulation in your program? How effective is it? Okay. A systematic program evaluation should be ongoing in order to make program improvements. And all of us that are in our organization or SIM centers are under some accrediting bodies. And accreditation is requiring that we look at our SPEs. How are our simulations? If you have simulation inside of your program, they want to know too how effective it is. In real time, teaching methods, student learning outcomes, and discussing the fit of the mission are all part of program development and all should be systematically evaluated. Okay. Number 5, the simulation educator understands deliberate practice when they state it has an outcome of developing perfect skills. It is a method to evaluate and grade skills. It is a method to ensure appropriate formative evaluation. It is a method to use to become competent in skills. That is so correct. Because you remember we talked about it earlier. Deliberate practice is when you have that student putting that Foley in over and over again, and you're providing feedback. They keep crossing over the field. Nope, you got to do it again. They keep crossing over that. I need you to do it again. Oh, and now they put their sterile field together, and now they're leaning on it. So sterility is a big issue for them, which leads to unsafe outcomes for your patient. So you have that student deliberately going over and over, providing that formative feedback along the way. And it really does lead to a method that would help that student become more competent and go to a state of proficiency. We know the outcome of developing perfect skills. No, that's not the outcome of deliberate practice. We want them to be proficient. It is a method to evaluate and grade students. No. It is a method to ensure appropriate formative evaluation. No, because we can provide it, but it's not. Nope, that's not what it is. It is a method. When you look at our choices, the best answer choice is a method to use to become competent in skills. That's our goal when we're using deliberate practice. Having a student that's struggling, you as that simulation expert will set up labs, but you're able to help that student go over and over, implement deliberate practice. Because we're moving that student to a place of competency and confidence. It also helps with increasing confidence. Deliberate practice is used as a teaching method to assist learners in becoming competent in a skill. Deliberate practice is not used for formative or summative evaluation, and the intent is not perfection. The intent is what? Competence. Number 6, a student who is practicing insertion of central lines in a hybrid simulation with a standardized patient is learning mainly in which domain? A, affective and psychomotor. B, psychomotor and psychosocial. C, cognitive and affective. D, psychosocial and cognitive. Hands down. Yes. We have 2 domains that we're looking at here. And we have affective, which is our emotional part, right? And we also have our psychomotor. And because we have that standardized patient, we can really see if that needle really hurts. He's probably going, oh. So we're going to really be able to see that. If that is infiltrated and they go to flush it to check patency, and that patient starts, oh, that hurts. And initially it did with that saline, but it's continuing to hurt. That real patient is going to let them know. Okay, that's the affective. Psychomotor is the skill itself of inserting that central line. Psychomotor and psychosocial. Psychosocial is not a domain. Cognitive and affective. Not cognitive, but affective, yes. And psychosocial and cognitive, again, psychosocial is not a domain, but cognitive is. But this example is actually showing learning in the affective and the psychomotor. Okay. Standardized patients represent the human-to-human interaction needed in the affective domain, while a hybrid mannequin or part task trainer is used to promote skill development, which is mainly in the psychomotor domain. Cognitive domains address why something is being done, while psychosocial is not a labeled domain. 7, a scenario in which a student is telling family members bad news about a patient is developing skills in which domain? A is correct. Again, we're looking at the what? Affective domain. Affective, because we're providing bad news, which is going to elicit some emotions, right? Psychomotor is more of the skill, the knowledge applied to that skill, how they're doing that skill based on the knowledge they've learned, and the knowledge is what they do know. Psychosocial, again, is not a domain. Affective domain development is needed to discuss critical information with patients and families. Cognitive is important for knowing why, but psychomotor is not usually a major factor, and psychosocial is not a domain. So we put students in these scenarios so that we can help them respond in a healthy way. You know, and if we exposed it to them in the sim lab, hopefully when they're faced with it face to face with a patient, they'll know what to say they develop therapeutic communication. Okay. Number 8, a student who is calculating the correct dose of morphine dosage in a simulation to complete a patient controlled analgesic PCA pump setup is developing skills in which domain? A, affective, B, psychomotor, C, cognitive, D, psychosocial. C is correct. Again, we're finding out, do they understand? What knowledge do they know about what? Dosage calculations. So that is exactly what domain that we are assessing. Affective, again, is the emotional, their values, how they feel, how they're responding emotionally. Psychosocial, that knowledge, how are they using that to complete a skill, task skill. And then cognitive is what they know. Do they understand dose over volume? Do they understand how to convert pounds to kilos? Do they understand kilos to pound? How do they understand how to use the correct dose calculations? That's more in your cognitive area. And then D, psychosocial, again, is not a domain. Number 8, cognition is needed to understand correct calculation and correct dosage. Psychomotor comes into play when setting up the pump, more of the skill, the knowledge they know, the skill of programming the pump. And affective is how the treatment is described to the patient and the family. Are they apprehensive, a little nervous? I don't want to mash the button because I think I might get too much. And then psychosocial, again, is not a domain. Number 9, a fundamental simulation principle for educators to consider is A, student learning outcomes should match the simulation being designed. B, always use the lowest simulation type to accomplish an educational task. C, the more real the environment, the better the learning outcomes will be. D, all students should be exposed to all simulation types. And I know everybody was going to get that one correct. Because if not, we was going to have a conversation. Yes, yes, yes. Learning outcomes. If you ever see that, you're going to always get that one right on the CHSE. I know you will. It must match the simulation design. Student learning outcomes should drive the simulation methodology. Although using the lowest simulation type is good to conserve resources, it may not impact learning. Realism does not always ensure the objective student learning outcomes are met. Making sure all students are exposed to all simulation types are not necessary. Number 10, the novice simulation educator needs a better understanding when they include which of the following attributes when describing simulation feasibility. A, efficient, B, effective, C, available, D, achievable. Correct. Is it available? Available. The novice simulation educator needs more understanding. If they said that available actually describes or relates to feasibility. No, feasibility relates to the transference of those skills. Available is not one of the attributes of feasibility. Feasibility has to do with transferability of the simulation skills in the clinical environment. Can they move those skills forward? Skills are needed to be effective. Excuse me. Excuse me. Because if they're effective, they're able to transfer that over into clinical practice. They need to be efficient. They need to be able to manage those patient care loads, and the competency or skills should be achievable. Okay? Excuse me. So this is a good time for a break. Okay? So we're going to go ahead and take our first 15-minute break, and we will be back at 7:15 Eastern Time. Hey, hope everybody had a good break. We will start with chapter 16, planning simulation activities. We'll start looking at our goals: smart, measurable, attainable, achievable, realistic, and time stamped. So we're on page 271, and we're going with question 1. Everybody good? Okay. A novice educator is developing goals and objectives, outcomes for a planned simulation. Identify which statement is an example of a well-written objective. A, at the time of simulation, learners will understand the importance of good technique. B, following the simulation, learners will identify important concepts related to IV therapy. C, upon completion of the simulation, learners will appreciate the skill required to insert IV catheters. D, after the simulation, learners will demonstrate the correct steps for IV insertion. Excuse me. Good. Robert, can you tell us why D is the correct answer? Why did D stand out? Why is D correct and A, B, and C not?
I was actually kind of between B and D on this one,
Okay.
because initially with B, I thought it was a more well-written objective because they're going to identify important concepts. I ended up landing on D because, to me, I kind of thought if they're going to be demonstrating the correct steps for IV insertion, maybe that's basically more saying I'm going to have them demonstrate how they need to do this, and that, I don't know, I was kind of stuck in between those two, and I ended up just going with D, honestly.
Okay, so let's look at it. So when we're thinking about our objectives, they need to be specific, right?
Mm-hmm.
They need to be very specific. They need to be able to be measurable. Can you evaluate it? How can you measure it? And they need to be attainable. The student should be able to achieve the goals. It should be realistic. And then it needs to be realistic. It's not you asking the students to do something that really don't make sense, right? And then it needs to have a timestamp on it. When should it happen? So when we look at the completion of the let's go with the one following the simulation. So following the simulation that's the time, right?
Mm-hmm.
Learners will identify important concepts. What are the concepts? Is that very specific or is more general?
It's general.
It's more general. So that's what's going to take that one out. It's going to eliminate it.
Yep.
Okay.
There we go.
You
Yeah, I was
got it?
stuck in between those two. So
Mm-hmm.
I ended up guessing D, which I guess I got it right. But
Yep.
but
Yep.
I was kind of between B and D, but that makes a little bit more sense now why D would be right.
Yep. So if you remember that specific, smart,
Mm-hmm.
specific, measurable,
Attainable,
retainable,
realistic,
realistic, and timestamp. And even if you need to write it on that paper, but just make sure you go back over it because this is 40% of the exam, okay?
Yep.
And you should be able to see that in there. So when you get an example, you should be able to pinpoint each part, just like what we just did. At the completion of the simulation, that's the time, right? We're going to look at A. At the completion of the simulation, that's the time. It's going to be at the end, right? Learners will understand. Can you really measure understanding? How are you going to measure that understanding? So that one's really not measurable, right?
Nope.
The importance of good technique. Good technique of what?
Right.
Is really not clear either, right? So that one really doesn't have any clarity. It's really not specific because it's not just talking about what good technique. So that really eliminates A. Is it realistic? We don't know because we really don't know what good technique they're talking about. Okay. Then we already did B. Let's look at C. Upon completion of the simulation. So we know it's going to be at the end or at the end of the simulation, right? Learners will appreciate. So how can we measure appreciation? How can we measure that? Is that measurable?
Nope.
Mm-mm. The skill required to insert IV catheters. So we know it's going to be the skill. It's going to be IV catheter insertion. So that's pretty specific. But we got to see it's not measurable, right? Is it attainable? Well, we don't know really, right? But when we look at D after the simulation, we have our time. Learners will demonstrate the correct steps. So it's very specific. It's time. And it's also telling us how we're going to be able to measure it. Because guess what? If they're going to demonstrate steps, we should have a what? Checklist. So we should be able to look at that checklist and be able to tell what steps they did correctly and what steps they did incorrectly. And that's how we'll be able to measure that. You see it? And it's realistic because that is a psychomotor skill. There are steps to what? IV insertion. So that makes sense, right? It's realistic. Is it achievable? Yes, because we can teach them that, right? And they can achieve proficiency in following those steps to insert an IV safely. And the time we saw that at the beginning after the simulation. So we're going to walk them through the steps in this simulation or the simulated experience. It could be a task trainer, which would be a task trainer, and you're walking them through how to insert an IV. And you provide them the checklist. So D is the correct answer there. Because you can see each component. Okay, everybody good with that one? Okay. D, the objective precisely states a concrete short-term behavior that the learner is expected to accomplish following the simulation. The verb that is used is specific with little room for variance in interpretation. This objective is also written using the ABCD rule, which includes the audience, behavior, condition, and degree. The objective is measurable. Again, understanding is difficult to measure. So you be careful of those type of objectives because that's really pretty subjective. You can't really measure that. It's hard to measure. I'll say that. How about that? Identify is a low-level verb on Bloom's taxonomy, and appreciate is also difficult to measure. Okay. 2, a simulation educator is planning to use formative evaluation. Thank you, Robert. Thank you. A simulation educator is planning to use formative evaluation during a simulation exercise. Which statement indicates that additional knowledge of the types of evaluation is needed? A, I plan to use a form to provide learners with feedback about their performance. B, I will develop a rubric for faculty use in grading the learner's performance. C, I will meet with learners individually to discuss any areas needing improvement. D, I want to provide adequate time and opportunity for learners to self-reflect. Yes, our answer is B. Who would like to explain or provide your rationale for choosing B as the answer?
I choose B because it had obviously the formative evaluation, which is specifically able to evaluate what they may need to reproduce or improve on, is the word I'm looking for. So you're able to identify what needs to be improved through the official formative evaluation.
Exactly. And B is saying that you develop a rubric in grading, right? Informative evaluations, are we really providing grades as a final? No. You're so correct. You are moving that student along to be graded when we're formative, right? You're providing that feedback as they're performing so that when it's time for them to be graded, they're at a place where they should be successful. So when you're talking grading, you're at the summative evaluation, pass, fail, or grade. But when you look at, I plan to use a form, so they're saying this simulation educator don't understand what formative evaluation is about. If they're saying they're going to use grading to evaluate the learner's experience or performance. But when we look at A, I plan to use a form to provide learners with what? Feedback. Oh yeah, that's what we're doing when we're doing formative evaluation. We're providing them feedback. And I like to say you're forming their learning along the way until you get them to that place where they understand the concept or they understand and they're able to be successful to pass that test or to pass that validation. C, I will meet learners individually to discuss any areas needing improvement. Yes, because as I meet with that learner, I'm going to show them and talk to them. I'm going to watch them do the Foley insertion and I'm going to provide them feedback. And then they're going to come back and then we're going to meet again, or they may stay in that same lab space and then they're going to do it again. And I'm going to provide them more feedback because they have validations next week and I need them to be successful for that summative evaluation. Because when they get to that validation, that's going to be pass, fail. I will meet with learners individually. Okay, we did that. I want to provide adequate time and opportunity for the learners to self-reflect. Again, that's great because as you provide them feedback on their skill where they may be unsafe, they have an opportunity to say, "Oh, okay, I see what you're saying. I did cross over that field, so I need to keep my exam table at waist level. I don't need to be leaning over it." And then they start thinking, what else can I do? Can you show me another way that I don't keep crossing over this sterile field? That's formative evaluation because then you're going to provide that information. And then that students, the next time you watch them perform, they should make some corrections and improve. Okay. Good, 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 good. During debriefing, number 2. During formative evaluation, simulation educators provide feedback in order to facilitate learning and identify areas that need further reinforcement or improvement. Although formative evaluation can be graded, this is more often associated with summative evaluations. A form can be used. Learners should be provided time to reflect, and students should be provided feedback for formative evaluations. So when you think about the comment it made, it can be used. They still are going towards that. So when we talk about them having a grade and then they using it as formative, that would be in your classroom when at the end they take their final exam. Okay, because they're going to take those mini exams along throughout the course, right? And then at the end, they're going to get that final exam. And that's when it's used as in a formative way. But then at the end, they get to take that final. And that means they're either going to pass or fail your course. End of the semester or end of the academic year, end of the semester or end of the quarter grading. Okay, that's what they're stating in that. Number 3, a course coordinator is discussing debriefing with the clinical adjunct faculty. Which statement demonstrates that the educator has a clear understanding of debriefing? Okay. Debriefing is a great method to use when teaching students using task trainers. B, incorporating debriefing is the best way for students to acquire short-term learning. C, during the debriefing process, students have the opportunity to assess their performance. D, debriefing can be used as a graded evaluation of student learning. Correct. Our answer is C. Debriefing. During the debriefing process, students have the opportunity to assess their performance, and that's true in a psychological safe environment. Not in a punitive environment, but in a psychological safe environment. Because once we ask them the questions, they're going to reflect back on that behavior, right? And if we ask our questions in the correct manner, depending on what debriefing tool we're using, students have the opportunity to look back over their behavior or assess that behavior and actually make changes in a safe way. Okay? Debriefing is a great tool. A said debriefing is a great tool to use when teaching students using task trainers. Well, you can use it at the end after you finish that skill. You're just kind of going back over what that's not the best answer for this, a clear understanding. Incorporating debriefing is the best way for students to acquire short-term learning. No, we want long-term, right? Because we're wanting to change unsafe behavior to safe behavior. So that when they go out into their clinicals, they are able to provide safe care and increase our patient outcomes to being healthy and safe. D, debriefing can be used as a graded evaluation of student learning. No, that's not what we're wanting to do in debriefing. This is a time of reflection, assessment, replay, looking back over their behaviors so that we can talk about it and have them talk about it through our questioning, not a time to teach, not punitive, and so that they can change their behavior moving forward. During debriefing, students have the opportunity to process what they have learned and to use feedback provided by the faculty and peers to reinforce their learning and identify areas for improvement and growth. Debriefing should be used for all simulation modalities used for learning and should add to the students' long-term memory. Debriefing is not a graded process. 4, feedback is an important part of the evaluated process. Identify which one statement is most important in providing learners with effective, useful feedback. A, standards or criteria should be developed so that the faculty are consistent in their grading. B, feedback should only be provided by the course or simulation coordinator. C, only positive feedback should be shared if the observer misses part of the simulation. D, an observer can provide feedback when they lack knowledge of good performance. Yes, A is our correct answer. Someone would like to share? Why did you choose A?
B and A, when you're doing feedback, you can use grad students, you can use adjunct clinical instructors. That's why B's wrong. C, you should give positive and negative feedback. Even if the observer missed part of it, if the student done something wrong, they should still have constructive criticism if they need it. And then D, an observer can provide feedback if they lack knowledge of good performance. Anytime you're having somebody observe a student, it should be somebody who is a content expert. That's why whenever you're planning, you're checking to make sure you have content experts.
And know how to provide feedback, right? Yes, and understand what performance looks like, right? And what were our criticals, What were we looking for? What was the student supposed to do in the simulator? They need to be knowledgeable of that, right? That they met each one of those goals, each one of those points to move from set one to set two or scenario phase one, phase two. What were those criticals within each one of those sessions, each one of those scenes, those scenario scenes? They need to be knowledgeable of that. You're right, to be able to provide that feedback. Thank you, Robert. That was good. And standards and criteria should be developed so that faculty are consistent in their grading. Remember, your evaluation tools, evidence-based, valid, reliable, right? We need to make sure we've been researched, we have supporting research to confirm or affirm our validation evaluation tools. And whoever's using those evaluation tools, they need to know how to use them. So we need training on those tools so that everyone is able to grade our students in the same consistent manner. It is important that the person observing and providing feedback has expertise in the content and knowledge of what constitutes a good performance. Standards or criterion help ensure that all observers are consistent with their feedback. Rubrics are often helpful in this regard. Feedback can be given by others, such as simulated participants. Feedback does not always have to be positive. Observers need to understand what competency standards are expected. And again, going back to that feedback, one of the groups, modalities we need to remember is our standardized patients. Standardized participants. That's one positive thing that they can do, among others, is what? Provide feedback. They're not the evaluators, but they can provide feedback to the students, right? And then you, as the simulation faculty, are able to take that feedback to give that final evaluation to that student of their simulation experiences. 5, a simulation educator is planning to use an objective structured clinical examination, OSCE, to evaluate learners at the conclusion of their Adult 2 course. Which statement is the most accurate description of an OSCE? OSCEs have only been found to be a reliable evaluation tool in medical education. B, an OSCE is a valid assessment tool for evaluating competencies and judgment. Correct. A self-assessment would provide a more valid method of evaluation than an OSCE. A newly created checklist would have higher validity than an often repeated OSCE. And everybody is correct, B. So who would like to share? Why is B correct? That's good. B is our correct answer. Who would like to share briefly?
A can be used in nursing education and medical education. Self-assessment is going to be more subjective. If you're wanting to evaluate somebody, you need to have an objective assessment, not allow them to do a self-assessment. And then a newly created checklist doesn't have validity as opposed to an older checklist, which would have higher validity if it's been used across different groups and it's been successful with them. So
Yeah, that's right. It's being repeated. Exactly. Versus one that's new that hadn't even been used before. Exactly. And that self-assessment would provide a more valid method of evaluation. You're correct. And then an OSCE. An OSCE, yep, you're correct. An OSCE is a valid assessment tool for evaluating competencies and judgment. Multiple stations, right? And depending on where we are with that OSCE, it could be a formative OSCE or it could be a summative. Most of them are summative, but it could be either way. OSCEs have been used for years as an evaluation tool in medical education, but they have also been found valid in evaluation of skills and competencies of other health professions. In our medical professions, you see them a lot as the summative, right? In our nursing, we're using them too as formatives. In choosing a tool for evaluation, it is important to consider the validity and reliability. It's reliable. We've tested it over and over again. Of the assessment, OSCEs can be used in healthcare disciplines. Self-assessment is a different type of evaluation, and a newly created checklist would need to be tested for validity and reliability. Okay? All right. Number 6, a first-year faculty is going to incorporate simulation into the adult health course for the first time. Which statement indicates that they have a clear understanding of planning and organization of the simulation experience? A, the simulation should last as long as the learners would have been in clinical setting. B, to minimize faculty time involvement, each simulation can include up to 12 learners. C, learners will have the opportunity for hands-on practice with skills during the simulation. Or D, a scenario including a pediatric patient with asthma would be a great learning opportunity. C is correct. Would someone like to share? Would someone like to share why D is incorrect? Why is D incorrect? A scenario including a pediatric patient with asthma would be a great learning opportunity. Why is D incorrect?
Well, if you're talking about adult health,
Exactly.
course, really doesn't involve pediatrics.
Exactly. Exactly. Exactly.
And
So
A,
I'm sorry, go ahead.
it shouldn't last as long as if it would be in clinical.
Mm-hmm.
There is no real set number. So, but I've never seen one go up to 12.
Exactly. That's not healthy for the learning environment. The smaller your groups, the better of the opportunity of having a healthy learning environment, the smaller your group. So that is a large number of students in one simulation. You are correct. Okay, C, learners will have the opportunity for hands-on practice with skills during the simulation. Okay. Thank you, Andy. Students are able to practice skills competency and interact with the faculty to achieve the learning outcomes of the simulation and course. Simulation learning is not necessarily a set time commitment as direct clinical experience because it is more intense. Matter of fact, we have the 2-to-1 and some a 1-to-1 ratio, you know. The number of learners depends on the scenario and the course objectives can fluctuate. It is an adult health course, so a pediatric experience would not fulfill the student learning outcomes. Okay. Number 7, the simulation coordinator and the course faculty for the psychiatric mental health course are discussing the best way for learners to practice communication skills. Which modality would best assist learners in attaining the skill set? Low fidelity with a standardized patient. B, high fidelity with the mannequin. Mixed fidelity with the mannequin. Low fidelity with the task trainer. And A is correct. Why would A be correct? What makes it the best choice out of all of our choices here?
Well, we know the SPs are always the best choice, but the communication part.
Exactly. Thank you, Kelly. Exactly. Standardized patient and communication. Correct. Thank you. Standardized patients are effective in the practice and acquisition of non-technical skills such as communication, therapeutic use of self and patient advocacy, high fidelity mannequins, mixed or hybrid simulation, and low fidelity part task trainers do not offer or afford the interpersonal communication needed. So any question centered around therapeutic communication, and you have to choose your modality, your standardized patient is your choice because they can talk. They can provide that feedback. They can provide conversation back and forth with that student to help them achieve therapeutic communication. Number 8, a simulation educator is planning to use high fidelity simulations for learners to utilize clinical judgment in a scenario in which the patient is rapidly deteriorating. Identify one action that will best ensure that the simulation runs smoothly and effectively. A, list the equipment that will be needed for the simulation. B, identify additional content experts that can be used for future simulations. C, book simulation space at least 6 months in advance. D, schedule a trial run with key personnel in advance of the simulation. In advance of the simulation. D is correct, and they're talking about what? What are we talking about in D?
Pilot
What's
test.
Exactly, piloting your simulations, and that's best practice. Again, I think we talked about it before. Don't look at what you're doing in your practice. This is one of those ones you got to close your eyes and say, best practice says I should pilot this sim before we do it. Okay, that's best practices. You're doing a new sim, you need to go ahead and run that sim so that everybody, a part of that sim, you'll be able to evaluate. Are there any areas where, oh, that's not going to work. The students are going to get lost. We need to change that. We have too much moulage. This is not flowing well, so that we can change those things before we bring our learners in. So you're exactly right. It's talking about piloting your sims.
I have a question, Dr. Scott.
Uh-huh.
In your experience with pilots specifically, have you encountered faculty pushback with that? And if so, how do you approach that?
Yes and no, because a lot of times it's very hard, to be honest, because of sometimes how our simulations are threaded. It's hard to really always get a pilot in, right? And so what I find out, I may not pilot it with my faculty, but I pilot it with my sim faculty, right? And you can also use, like if you have work study students, you can always bring them in as well, or someone that's just not in the classroom, because a lot of times the pushback is because they're teaching and they don't have the time to come down, you know what I'm saying, to actually run that sim. They may only have the carved out time that they have on the day they're supposed to be in the sim lab. So that's why I said yes and no. So sometimes if I can't, if I say, we're doing your pediatric sim, and I would like for you to come down and do the sim, she may say, I got a test. I got a da da da. That's when I say yes and no. So then I have to really circle back and use the people that are in my lab. Now, if you're one person running that sim, that becomes very challenging. That's why I said that's when I can't look at what I do, because I may not get the pilot sims all the time because I'm that one person running it. You see what I'm saying? So, but the alternative is to look around in your department. If I'm doing a community sim, I may even ask the administrative assistant, hey, are you busy on tomorrow? I'm going to do a sim and I would love for you to sit in. And you can give her a script, just to see and put them in those fillers that can be very helpful. Was that okay?
Absolutely. I appreciate it.
Yes. Because it's hard to really, unless you are fully staffed. And when I say fully staffed, you can have a director that's dedicated to sim. You can have a simulation faculty person or facilitator or coordinator. You have a sim ops, right? And you may even have an administrator. So that's a fully stacked, or you may have someone else. So if you have all of those roles, you can, you have people you can kind of help float around. But if not, I reach out throughout the department. We have other departments too inside of our building. So we've also went to other departments. Say, hey, what you doing today? We need some help. And they get excited because they want to know what we're doing in simulation. So they get excited to come and be in those roles and kind of help us pilot. But most of the time we're piloting it amongst ourselves. Anybody else have any feedback? Well, how you doing? Or is everybody, you don't have to speak in piloting sims, but everybody, how do y'all do that in your spaces?
I mean, we were really lucky that most of our sims have been concrete for a few years. So Andy, Courtney, and I have just kind of been able to jump on board with things that are well established.
Good. You can do on the fly and all that kind of good stuff because you've ran them a lot, right? That's good. Yeah. Okay. Good discussion. Let's see. Number 9, a team of faculty are planning a large simulation involving multiple standardized patients. Which statement indicates that the faculty need further guidance in their plans? A, we need to consider budget funds available for paying professional actors. B, we could work with faculty from theater to involve their students as standardized patients. C, if our standardized patients don't show up, we can use any students or faculty available. D, alumni could be asked to volunteer as a standardized patient. Yes, and we've touched on this some when we talked about SPs. What's important about having a standardized patient in your simulation? When we look at C, it says if our standardized patient don't show up, we can use any student or faculty. What needs to be done with that standardized patient?
They need to be trained, need to be given
Exactly. Again, you might have to do this, but you need to think about what's best practice. Okay? Best practice is your standardized patient participants need to be trained. They need to be vetted for that simulation. They need to be interviewed. Are they appropriate? You know, even to the point of a history. What is your history? Because if you're doing a sim in psych and it's suicide and they have suicidal ideations, they have a history, you're not going to let them participate in that suicide sim. So best practices said we should interview our SPs. You know, and most of them have like a checklist, an application, a true application that they actually go through to fill out, because then we're going to make sure we vet those SP standardized patients in the appropriate simulation, right? You do not want to put one in there and just pick them up, say, hey, you come over and do this. They sit in that room and then they have a trigger and something happens. That would not be safe, right? So we need to consider budget funds available for paying professional actors. That's correct, because guess what? Most programs that have the funding, they do pay them, right? We would work with faculty from theater to involve their students as SPs. That's correct. That's a very healthy way. That's what? Inexpensive, because you can help those theater students maybe get credit for their course. Put it on their resume. So that's a very inexpensive way to do SP in your program if you have access to theater students. D, alumni could be asked to volunteer as standardized patients. Again, we need to make sure we're vetting them in the appropriate ways, and we're doing a nice evaluation and making sure that they are trained for those SP positions. Standardized patients are oriented to the simulation scenario. Putting others in the role may not yield the same results and may not be effective. Paying professional actors to perform as standardized patients can be costly, so other alternatives, such as alumni, drama students, and other healthcare students, should be considered. In the place that they're being considered, the bottom line is they need to be trained, okay? Because if you're not careful, you put them in your sim, they may do too much. And if they exaggerate too much, they're going to take those students away from the outcome. They won't be able to achieve them, because guess what they're going to do the whole sim? They're going to giggle and laugh. They won't learn anything because that SP is just really acting out of character. They don't have no script. They haven't been trained. So you've just wasted that whole simulation experience. Okay? 10, while discussing pre-briefing with their mentor, which statement by the new faculty member indicates that further information is needed? A, debriefing. During pre-briefing, I plan to review information relevant to the scenario. B, learners will have the opportunity to familiarize themselves with the laboratory during pre-briefing. C, I will orient the learners to the capabilities of the mannequin during pre-briefing. D, the learners will be able to complete all their prep work during pre-briefing. Yes, they're not. This is not a time to complete pre-work. It should be done prior to the simulation. Your other choices are correct. Those are the things you do in briefing, in your briefing session. Make sure you understand and review. I keep talking about those ANASCO best practices, those articles. Make sure you understand them and go through them because this is 40% of our CHSE exam. Preparatory work should occur before students arrive for the simulation experience. Pre-briefing is a time to orient students to the simulation environment and equipment, discuss information relevant to the scenario, and answer any questions. Our fiction contracts. Psychological safety is initiated and established in that briefing session. Timeline, their expectation, their learning outcomes, objectives, what we're expecting, all of that's achieved. Time to huddle, handoff report, all of that's achieved inside of that briefing session. Okay, any questions? It's 7:53. We can go ahead and do our last chapter 17 if you like. If everybody's okay, we can thumbs up. If we need we do have another 15-minute break. Okay, we're going to keep rolling and then we'll get your 15-minute at the back end. Is that okay? Everybody good? All right. Let's move forward to debriefing. Debriefing, page 289, number 1. The novice simulation educator needs further instruction when they are facilitating a debriefing by A, observing the entire simulation, B, taking notes on observations during the simulation, C, using an experienced debriefer as a consult, or D, starting debriefing students one at a time. Yes, starting debriefing students one at a time. This is not, you would not do that. Debriefing is done in a group, right? We're debriefing them in a group. They simulated together. We need to debrief them together. It is not, it isn't time to observe the entire simulation, observing me and reflecting on that simulation, the behaviors, what went well, what would you change? I was concerned when you did this. Tell me what you were thinking. So it's a time of observing that entire sim, taking notes on observations during the sim. Yes, we can do that. Doing that facilitating debriefing, we've taken notes and we can talk about those. And we can also take notes while they're in there actually reflecting. Using an experienced debriefer as a consult, it can be helpful to have that experienced debriefer in there alongside that novice, because this is a novice simulation educator, right? And you typically don't want them, and you wouldn't want a novice simulation expert in their debriefing because they probably don't understand what the debriefing methods, right? So having that expert in there alongside them would be very helpful. So D means that they really don't understand what debriefing is. D is the answer. That's correct. Debriefing should be completed in a group format and not one student at a time. Simulators should watch the entire scenario, take notes, or use a consult if needed. A simulation educator is very new to the debriefing process. Which method of debriefing might be easier for the debriefer to start with? A, debriefing with good judgment. B, case study debriefing. C, debriefing for meaningful learning. Or D, advocacy inquiry. And why would, okay, I'm gonna give you a few more, sorry. Why would B be our correct answer? Case study debriefing. We're thinking about a simulation educator that's very new. Why would case study debriefing be easier?
Like easier and less pressure.
It's easier and less pressure, and they're probably typically doing that in education already, right? Case studies are used widely throughout. So that's one that's easy to use, especially when you're looking at the other debriefing methods that really require training. And I have a resource sheet in your folder as well that really talks about the debriefing techniques and give you some examples. Let's see. Case study debriefing may be less intimidating because healthcare educators are used to using case studies in the didactic and the clinical education. Debriefing with good judgment, debriefing for meaningful learning, advocacy inquiry are techniques that are very effective but takes professional development and practice. Ideally, the debriefing time, we're number 3, should be 5 to 20 minutes long, half the time needed to complete the simulation, equal to the time needed to complete the simulation. D, double the time needed to complete the simulation. D is our correct answer. Okay. All right. Debriefing is where much of the learning takes place and should not be rushed. It usually takes approximately double the time of the simulation scenario. Trying to debrief in a short amount of time may not allow the learners to reflect and synthesize what happened and what should be learned from the simulation. Making sure those students get to the end. The goal is what? To make sure that debriefing session is most effective when those students, you can see that they have achieved those learning objectives of that simulation. Okay? The debriefing method in which the simulation educator facilitates the identification of what went well compared with what can be changed. Next time is called A, debriefing with good judgment, B, case study debriefing, C, debriefing for meaningful learning, or D plus delta. Plus delta is our correct one. Easy to use, right? And may really use who you want your novice simulation debriefers to use. Plus delta because it's easy, right? And you can really use that in a very effective manner. Tell me what went well and tell me what behaviors you will want to change the next time. Plus delta is the technique that starts with the things that went well and then moves to process improvement. Case study debriefing discusses aspects of a case in chronological order. Debriefing for meaning learning and debriefing for good judgment are more issue focused reflective discussions. Okay. The debriefing method in which the simulation educator focuses on diffusing, discovery, and deepening is called A plus delta, B debriefing with good judgment, C 3D model of debriefing, or D debriefing for meaningful learning. Okay. C is our answer. Who would like to talk about 3D model of debriefing? How is it different than your other debriefing models here? We've already talked about plus delta.
Yeah, plus delta uses kind of like a checklist, what went well, what didn't go well. Debriefing with good judgment, the debriefer is going to act more like a patient advocate. And then debriefing for meaningful learning focuses on learner engagement, reflection. They use Socratic questioning. So 3D model of debriefing, whenever I talked about diffusing, discovery, and deep learning, that's what led me to that answer choice.
Exactly. You reflect on the experiences, identify what was meaningful, right? What the mental models were, and that led to the behaviors and the cognition. 3D model of debriefing. Diffusing, let's talk about it. Discovery, what was new, what did we learn? And then we look at the deepening. Let's take a deeper dive and tell us what actually is going to come out of what we did learn to move forward. The 3D model of debriefing. Number 6, the simulation educator wants to learn how to be an effective debriefer. The best method to use to learn debriefing is to A, read a book about debriefing, B, practice with an experienced debriefer, C, watch a video of a debriefing session, or D, attend a lecture on debriefing. Correct. Our choices, our answers. Practice with the experienced debriefer is the best way. Yes, reading a book, watch a video, and attend a lecture could help, but the most effective would be aligning that person, placing them alongside a veteran or experienced debriefer. Practicing with an experienced debriefer is very valuable and provides hands-on experience and valuable feedback. Practicing with an expert may be more effective than a video book or a lecture. Let me go back to 5 about 3D model of debriefing. The 3D model of debriefing uses the techniques of diffusing any immediate issues, learners discovering a learning opportunity, and the debriefing coaching learners to understand the meaning of the issue on a deeper level. The other techniques do not provide these elements, plus Delta debriefing approaches learning from starting what was done correctly and then moving to process improvement. Debriefing with good judgment shares critical information without producing defensiveness. Debriefing for meaningful learning focuses on clinical judgment by reflecting on the student's care and the patient's response. Number 7, a novice simulist needs further understanding when they state that the best way to choose a debriefing model is to A, review all available methods of debriefing. B, compare each debriefing method with your personal educational philosophy. C, test out each type of debriefing method. Or D, choose a method that works when time is limited. Better not do that. Now, this is when you're not looking at through your leaf. Best practices says you choose. You don't just choose one. Oh, we only got a little bit of time. No, 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 no. No, 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 no. A novice simulist needs further understanding when they say the best way to choose a debriefing method. You do not choose a method that works when time is limited. You need to review all available methods of debriefing. The one thing you do want to make sure is within your organization, within your group, is that we're doing the same, right? That most simulation teams have a standard debriefing technique that they use. And most of us use a combination of those. As you become an expert, you may not always use plus delta. You may bleed it in with your 3D. All of them may kind of come together. You're debriefing with meaningful learning. And then if you have a simulation where you know that the simulation itself warrants just plus delta, that may be the only thing you do with that simulation experience, but not because you don't have enough time, right? Compare each debriefing method with your personal educational philosophy. And that's what most programs do. They decide on which debriefing method is best for them and for their students and for the simulation faculty that are on board. If you don't have any simulation faculty that are experts, or they don't have any clue, they're using that plus delta. And then we give them some scripts, right? But you need to make sure you understand those that are debriefing. And that they understand what they're doing. In most states, in your board of nursing, they really are really strict on debriefing, making sure that those debriefers are educated, they're trained. Number 6, C, test out each type of debriefing method. That's a very good thing if you have time to do that, because we got to make sure everybody's comfortable with how to do that. And that comfortability comes from scripts as well. Having it written out and letting whoever's with us, we're going to write it out and we're going to follow this same script. And of course, we said D was incorrect. Debriefing time should not be rushed or limited. Reviewing methods, understanding one's own philosophy, and testing techniques are all important steps to finding a comfortable and effective debriefing method. Number 8, which debriefing method includes a technique called advocacy inquiry? Is it plus delta, A? B, debriefing with good judgment? C, 3D model of debriefing? Or D, debriefing for meaningful learning? Correct. It's B. It has the advocacy inquiry in there. We've already talked about each one of them. Debriefing with good judgment contains the advocacy inquiry technique plus Delta 3D model of debriefing and debriefing for meaningful learning do not contain the advocacy inquiry technique. And Robert did a good job summarizing those up for us. I saw this. Tell me what you were thinking. Number 9. The simulation-based educator is beginning the debriefing, and the opening statement is, I want to encourage you to share your thinking. This is a time to puzzle through your decisions and actions together. This is an example of which of the following positive educator behaviors? A, orienting learners and building trust. B, establishing learner and educator roles. C, placing responsibility of learning on the learners. Or D, placing the responsibility of learning on the simulation educator. A is correct. A is correct. We're really building that nice psychological safety, right? We're trying to bring it all together so that they can really feel safe in their learning. And if they make a mistake, we create that atmosphere. And we do that in our briefing state. The simulation-based educator is using an opening statement that orients the learners to how the discussion will be focused and their role to sharing their thinking. So it builds trust by laying out the objectives. It does not establish educator roles. It does not place the responsibility of learning on the learner or the educator. Learning is a shared responsibility, and that environment from that point at the start in our briefing is setting psychological safety. And we want to make sure we maintain that throughout the entire simulation experience. And oftentimes we may have to bring them back to it when we get ready to debrief, but it starts in your briefing. Pre-briefing and our briefing, that's when we set that psychological safe environment. Number 10, a new simulation educator is learning the process of case design, pre-briefing and debriefing, and is struggling with the concept of psychological safety. The mentor defines psychological safety of which of the following? A nice learning environment where difficult topics do not get discussed and the educator sidesteps all challenging questions. B, a learning environment where the instructor sets the stage as being instructor focused and learners can only ask questions when invited. C, a learning environment where learners can take interpersonal risks, speak up, ask questions, and discuss mistakes without fear or retribution. D, a learning environment where learners respect the educator, only speak when spoken to, and with hierarchy maintained. Now, I know y'all going to get that one correct because I just talked about it. Correct. It's C. So we created psychological safe environment. And C is our best choice. Okay. A nice environment where difficult topics do not get discussed. No. It's a safe environment so we can talk about those difficult choices and behavior, right? And educators should not sidestep challenging questions. We need to ask those Socratic questions. We need to ask those questions. I was concerned when you walked away from that bed with a needle and you just walked around the room. In a way, tell me what you were thinking about. Or I was concerned that you did not repeat those orders back to the physician before proceeding. We need to be able to talk about those questions. When the environment is safe, we can. B, the learning environment where the instructor sets the stage as being instructor focused and learners can only ask questions when arrived. We already know it's student focused, right? Student focused, so that's incorrect. And then D, a learning environment where learners respect the educator, only speak, that's not true, when spoken to and with hierarchy maintained. No, this is a nice, safe environment where reflection, conversation, of course, they're not doing anything disrespectful, but it's a nice collaborative environment. So that makes that one incorrect as well. Well, we have come to the conclusion of our session, and I thank you all for your participation on this afternoon. Let me read our last rationale for number 10, a team of learning or learning environment where participants can take interpersonal risks, speak up, ask questions, and discuss mistakes is the definition of psychological safety. A psychologically safe environment, learning environment is not instructor centered, nor is it nice, where participants can tackle hard topics. Behaviors that do not promote psychological safety include demanding respect, not inviting, speaking up, and maintaining hierarchy. Okay? All right. And again, some might have to put their eyes and close their eyes because you may see that in your area, but that is not psychological safety. And we have to, in a healthy way, because sometimes faculty that don't do debriefing, I have to say, whoa, I have to wheel my environment back. Environment. So we have to know how to do that in a healthy way to kind of grab that environment back and maintain it. Okay? And I do it so nicely. Well, okay. Well, let me see right now if we can talk about this a little bit. And we kind of massage that in. And I look at that faculty member or whoever person is, and y'all have the little eye contact going on. You start nodding your head, and they kind of know, okay, Dr. Scott is getting ready to say, I need to be quiet because I'm getting ready to mess up something. Because you can start seeing your students. They will automatically, their facial expression, and they will just start going down on you. But you are the experts. Okay? Well, I'm going to quit my talking because we're right at 8:13. Anybody have any questions? This was the first part of our educational principles applied to simulation. Please make sure you check your folders. And if there's anything else you may need, feel free to email me as well. And yeah, very good session on tonight. Can you believe we only have 2 more sessions to go? Next week we'll finish this one up. In the last session, I think we'll have 1 chapter to do, and then the rest of that session you'll be doing questions in the back of your book. I think we may be able to get up to about 25. Sometimes I've been able to get up to about 20, but we'll see what happens as we go through your last session of testing. Okay. Well, I hope everybody have a good evening and a good rest of the week. And I'll see you next week, okay? Thank you.
Thank you.
Bye-bye. Thank you. Bye-bye.